Thank you again for the kind invitation, and it's really a privilege to be able to speak to you all and speak to you about a topic I feel very passionately about. I mean, TAVR has really revolutionized the care of patients with aortic stenosis over the past decade, and we're only just beginning. There's a lot more good to do. There's a lot more patient trajectories that we can change in a positive way. And I just really want to talk about that and about kind of common management issues with these patients that you will all see. Here are my disclosures. I have disclosures across all of the interventional cardiology companies because I do a lot of teaching for them. I proctor new devices and kind of high risk procedures for the whole kind of gamut of interventional cardiology. I always kind of start my presentations with an overview of what a structural cardiologist does. So on top of kind of interventional cardiology, where we kind of typically look after patients with coronary artery disease and do PCI or kind of high or even high risk PCI, we kind of have really evolved into the structural heart space. And TAVR for the treatment of aortic stenosis is really the cornerstone of that. But we often do a whole host of procedures such as ASD closures, VSD closures. We now have really good data that we can improve patient symptoms and reduce heart failure hospitalizations in patients with tricuspid valve disease. We treat people with obstructive cardiomyopathy with alcohol septal ablations. We very commonly close PFOs in young patients who've had strokes we think are due to kind of shunting across the atrial defect. And then we do lots of mitral valve disease, either edge-to-edge repair, such as the MitraClip procedure, or valve replacement, both in native anatomy and in patients who previously had surgery. We're growing very, very busy in performing left atrial appendage occlusion, such as something called the Watchman device in patients with atrial fibrillation. Typically, we're kind of doing it now at the moment in patients who've got problems taking anticoagulation, but we'll have data next year. We're comparing kind of the Watchman to actually just DOAC anticoagulation to see which one's safer for patients. So that's kind of a very broad kind of area and a whole diverse range of pathologies within the heart that as structural interventionists we do. And it's just kind of interesting to know that TAVR is really the cornerstone of that. I was told to introduce a CME question just so we can get accreditation for this. So I'm going to just read it out and I'll kind of paraphrase a bit. It says, which of the following statements best reflects current evidence with regarding stroke risk for patients undergoing TAVR compared to surgical aortic valve replacement? Option A, TAVR is consistently associated with a higher risk of periprocedural stroke. Option B, the stroke risk is equivalent between TAVR and SAVR in high-risk patients, but significantly higher with TAVR in low-risk patients. Option C, contemporary data demonstrates that TAVR may be associated with lower stroke rates than SAVR. And option D, stroke is not a meaningful outcome to consider when comparing TAVR and SAVR in contemporary practice. So I just keep that in mind as we go through the talk. So we're going to kind of go over not only TAVR and what it does, but aortic stenosis, the importance of recognition of it, and where we currently are with TAVR, how to manage these patients, and what's coming next. I'm currently at the New York Valve Conference in New York, which is kind of one of the world-leading valve conferences, and the kind of next frontier for TAVR, both in terms of devices and really interestingly, medical therapy to stop progression of aortic stenosis is really exciting and might kind of really revolutionize how we look after valve disease patients. So as you all know, aortic stenosis is associated with aging. And I often tell patients in clinic, if you live long enough, your aortic valve will wear out. And that happens at different points for different patients, but the aortic valve does have a life expectancy associated with it. And when the valve begins to wear out, it becomes calcified, it becomes hardened and stenotic. We have this really kind of iconic graph from the 1960s, which was drawn by Bromwald and Ross, which you'll have all seen in your medical school textbooks, that show us that patients do okay until symptoms begin. And then when symptoms begin, we get a rapid decline in prognosis. And we talk about 50% mortalities at either 2, 3, or 5 years, depending on if you have symptoms of heart failure, syncope, or angina. Right now, we have no effective medical therapies to stop the progression of aortic stenosis, and it's really considered that it's a mechanical problem with a mechanical solution that's required. Timing of this intervention is crucial, and we'll talk about how we are reframing that timing in terms of when we should be intervening on these patients based on contemporary data. This is just a graph which I kind of used to show where we are as a population with the management of aortic stenosis. In the blue, and this is kind of the age of patients on the bottom axis, in the blue is the patients being treated with SAVA, which obviously has younger patients. In the orange is the TAVI population. In the gray is the patients that we know have aortic stenosis but are not treated, severe aortic stenosis, but for whatever reason are not treated. And in the yellow are the estimated population that we know based on screening studies of the patients out there with severe symptomatic aortic stenosis that are not diagnosed because either they've not sought medical attention or no one's auscultated their chest or got an echo. So we're really only at the tip of the iceberg in the patients that we're treating and the patients who we can improve their prognosis for. Echocardiography is really the cornerstone for diagnosing aortic stenosis. It's a progressive disease. It doesn't happen overnight, but it does happen at varying speeds for varying people. We go from a healthy valve, which opens freely, to a valve that generally gets more thickened, more calcified, initially with fibrotic material, and then which then calcifies, which causes a restriction and opening to the point where the LV has to struggle with every heartbeat to eject sufficient volume from the ventricle. This, again, we'll see progressively. Often we diagnose people for the first time at severe, but you'll often see patients with mild to moderate aortic stenosis on echoes, and we kind of keep those patients under surveillance to see the rate at which they progress. When you look at your echo reports, there's a number of different parameters that are used to kind of assess severity. I would say the most important one of these is peak velocity. So when you're looking at an echo report, you're really looking to see if a peak velocity is greater than 4 meters per second. If your peak velocity is greater than 4 meters per second, you have severe aortic stenosis. There's no kind of questions about the accuracy of the test or anything. A peak velocity of greater than 4 meters per second across your aortic valve is a significant problem. The next thing to look at is the mean gradient. And we're looking at mean gradients greater than 40 millimeters of mercury. And then based on a few calculations, we can also use the continuity equation to estimate aortic valve area. And we also kind of look as a threshold of an aortic valve area less than 1 centimeter squared. These are all the thresholds for conventional aortic stenosis. In patients with severe LV dysfunction, they may not be able to generate the gradients because the ventricle's already begun to fail, but their valve area still comes up less than 1. In those patients who've got LV dysfunction, we'd normally go and do a dobutamine stress echo to see if we can get the LV to pump harder to see if one of two things happens. Either the gradient goes up or the peak velocity goes up or the valve opens. And that's why you'll often see us in patients with LV dysfunction and calcified aortic valves ordering dobutamine stress echoes. There's another cohort of patients who are called low flow, low gradient aortic stenosis. These patients have, paradoxical, these patients have normal LV systolic function but have a low stroke volume. And these are typically what we call little old ladies with small ventricles who have a very small ejection volume. And because of that, they don't generate a gradient, but the valve is still problematic. We have real world data that shows that we can improve the prognosis by reducing mortality in patients with all kind of brands of severe aortic stenosis, be it conventional or low flow with a reduced ejection fraction or paradoxical low flow with preserved ejection fraction. And so that the onus of this is really on the reader of the echo scan to try and put it all together to determine whether the aortic stenosis is severe or not. But these are kind of the kind of numbers that you're going to look at underneath the echo report to see how they got there. Aortic stenosis is very prevalent. when we look at epidemiological studies, and this is just in a Scandinavian population on the graph of the left, we are seeing that almost 1 in 6 patients over the age of 80 have severe aortic stenosis. We're almost at the point where we can argue for screening for aortic stenosis in the elderly population, in a similar way that we do for abdominal aneurysms. We're not there just yet, but that might be a change in the next decade. We know that aortic stenosis kills people, and we don't have too much data in terms of medical management in contemporary fields, because we've always treated these patients. And the last kind of original partner studies, where they took patients with severe aortic stenosis that were not suitable for surgery, and they randomized to medical management or TAVI, showed that you could reduce the mortality by half in these patients by addressing their aortic valve. And so this, again, showed that we could rapidly and significantly improve the mortality of these patients. I'd really kind of belabor the point that you need to think of severe aortic stenosis like cancer. There is a mortality associated with waiting for treatment once you've made the diagnosis. And we see this all the time in valve clinic, but we see that when we look at registry data, when we look at from the time of referral to being seen in the clinic, if your clinic can see you within 1 month, 1 in 25 of your patients will have already died. If your clinic can only see you within 6 months, 1 in 10 of your patients with severe aortic stenosis will have died. So whenever we're referred a patient, I aim to have them treated within 1 month of referral to try and minimize this attrition, because it is really a progressive disease that will kill people. Despite this, we know that patients are undertreated. We know that the vast majority of patients who are diagnosed are not referred for treatment. And we know that that is despite both TAVR and SAVR growing in kind of prevalence over the last decade. We know that there's a huge difference between the referring physician and lots of kind of health equity questions with regards to referral for treatment of aortic stenosis. Depending on, like, there are certain providers, typically cardiologists, that will refer more, and certain providers that will refer less. And we can look at this in kind of various different charts. And we know that actually patients with severe aortic stenosis who are looked after by a referrer that refers everyone actually have better clinical outcomes than patients who are held onto by their referring provider. We know that there's probably a lot of socioeconomic and race-based and gender-based bias. We know that in epidemiological studies, the prevalence of aortic stenosis is similar regardless of race. But however, there is a significant reduction in Black people who are referred for therapy. We know that aortic stenosis is also as common in women as it is in men, but fewer men are referred for therapy. These are things that are important to kind of consider. We know that the disease doesn't offer a better prognosis dependent on race or gender, but for some reason, those patients are less likely to be referred. Just a quick overview of where we are with our treatment of aortic stenosis. Really, since the advent of cardiopulmonary bypass in the late 1950s and early 60s, aortic valve surgery was really considered. Initially with the Starr-Edwards valves, which is this ball-in cage valve, which you all may see or remember that a few of these still do exist, and we explant them every now and then. Pretty soon after that, people tried to find ways to avoid long-term anticoagulation by replacing the valve with something which is more similar to the biological valve. And so initially using cadaveric allografts and then using some tissue from the legs. But essentially, within a decade, they came to this Hancock graft, which is really a metal frame with the pericardium of a pig used to generate leaflets. And that's pretty much the design of surgical aortic valve replacements now. It hasn't changed significantly from that. And if you look at that valve, that's pretty much what the surgeons put in right now. And from 1970 till now, for the last 50 years, we've got very good at doing surgery. back then, when it was started, Ross and Bromwell drew this graph where these were kind of patients with severe aortic stenosis. And then when they developed symptoms, suddenly their prognosis without surgery would be rapidly in decline. Surgery at that time was associated with a huge upfront mortality, close to 15% of chance of dying during surgery, but it would often return you to a prognosis similar to that of the general population. We thankfully, over the last 50 years, surgery got a lot better at treating patients with aortic stenosis. And this is kind of registry data looking at the management of a surgical aortic valve replacement prior to the commercial availability of TAVR. And the vast majority of patients are low risk, and more than 100,000 people a year in the US, and what they are having having SAVR, surgical aortic valve replacement, performed at a mortality under 2%. And this is really good. So surgery got a lot better than when it started. And then there were still these patients that couldn't have surgery. And so in France, in Rouen, the late Alain Crebier performed the first transcatheter aortic valve implantation in a young gentleman who was not suitable for surgery but had severe calcific aortic stenosis. This is the actual fluoroscopy of that index procedure, and he took a roundabout way. Well, I'll just show you what we're looking at. We're looking at kind of an anterior-posterior projection over the spine. The heart sits around here. He took a wire up from the inferior vena cava, from the right atrium to the left atrium, across the mitral valve, into the left ventricle, and out through the aorta, down the descending aorta, and he snared it out through the femoral artery, and then used this as a rail to deliver a valve which was on a balloon, and delivered it through the right atrium, left atrium, across the mitral valve, into the place of the aortic valve, inflated the balloon, and left this metallic structure with pericardial leaflets sewn into it to act as an aortic valve. That patient did incredibly well and actually survived to tell his story across many years after that. But what that started really was an avalanche of technological discovery and iterative improvements to try and demonstrate that you could safely and effectively do transcatheter valve replacement to treat these patients. And over the last decade, we've had sequences of randomized clinical studies, all of these studies published in the New England Journal, that have demonstrated TAVR to be as good as, if not better than, surgery for the treatment of degenerative aortic stenosis. And we have two main platforms available in the US. We've got the balloon expandable platform, where we put a valve on a balloon and expand the balloon for the valve to stay in place, or a self-expandable platform where the valve will naturally take its expanded shape, but we crimp it down and then slowly release it in its place. The most recent of these data comparing TAVR with surgery was the PARTNER 3 study. That took 1,000 patients and randomized them between TAVR and surgery, and looked at the outcomes with regards to death, stroke, or rehospitalization. That demonstrated that not only was TAVR not inferior, it was actually superior to surgery in that regard. And what it also demonstrated in this low-risk population, which, if you remember from the epidemiological data from the STS databases, the vast majority of patients undergoing aortic valve surgery, that the risk of stroke was about a quarter with TAVR compared to that of surgery. The pacemaker risk was equivalent, and the risk of new onset atrial fibrillation was much lower with TAVR. So across really all outcomes that were assessed, TAVR was as good as, if not better than, surgery. And that really revolutionized kind of the volume of TAVRs happening in the US. And that kind of happened over the last 6 years. We know that this data continues through to 2 years and through 5 years. When you're treating elderly populations, these curves will ultimately have to coincide, because when you're treating a 75-year-old, regardless how good your TAVR result is, ultimately the patient has to die of something. And so the differences between these two groups will gradually come closer together. So, but even if initial data suggests that we're getting a good improvement. The other thing is often when we see these patients in valve clinic, they don't care so much about living longer, they just want to live better. And what we use in cardiology is something called the KCCQ score, which is a measure of quality of life. It kind of very objectively kind of measures what symptoms they experience whilst doing activities of daily life and how happy they are with their life. This is kind of the whole range of cardiac studies that have kind of been landmark over the last decade or so when we started using KCCQ scores robustly. And up here in this corner with the greatest benefit are the valve intervention studies. So these are the partner studies that we looked at TAVR versus surgery. And this is also the MitraClip study, COAPT for patients with mitral regurgitation and MitraClip. And valve intervention allows you to rapidly alter your patients, not only prognosis, but their quality of life. So in the guidelines at the moment, severe AS is recommended, and TAVR is recommended for patients with severe AS over the age of 65 or a life expectancy less than 10 years. That 65-year limit is as a result of, that's when Medicare kicks in. Medicare sponsored all of the randomized studies. And so because of that, all the patients that were in the study had to be over the age of 65. We take a more pragmatic approach and we kind of look at degenerative aortic stenosis as its own entity. We know that from registry data that we've got good, at least equivalence of durability of aortic valve to surgical aortic valves up through to 10 years with the NOTION study. And so that's kind of the whole range of treatment options from the advent of cardiopulmonary bypass to the discovery of surgical aortic valve replacement to then really the innovation of TAVR. And that's kind of really changed the way that we treat these patients. And that's a bit of the history of how we got to where we are. In terms of the patient pathway in what we do at USC, like I said before, it's really time is critical. So my aim always is from the moment a patient is referred, they are treated within 1 month. And that involves them having their necessary workup, which is typically a CT TAVR and a coronary angiogram, seen in valve clinic, had the TAVR procedure, which typically involves a 1 to 2 night stay, and then return them to whoever referred them to you. I see them in my clinic at 1 month and 12 months follow-up because another great thing that the US has done is that every patient who has an aortic valve replacement has to be in a national registry, and we have to report to the national registry data for our program at both 1 month and 12 months. And so that's what we do. And then other than that, they're seen by their referring cardiologist. This is a few familiar faces that you may see. The valve team is not just a cardiac surgeon or is just not an interventional cardiologist, but it's actually a very good example of how we can work collaboratively together to make sure that we make the right decision for the patient in front of us. And so I can very rarely do we ever have a disagreement on the right patient, on the right treatment approach for a patient. And it's actually a very good, effective mechanism for looking after these patients. The other two people definitely at USC that you need to know about if you're involved in the valve program or have patients with valve disease are NPs that kind of bridge the inpatient and outpatient world, Kimberly Tran and Amanda Bowie, and they kind of help run the clinic and also coordinate both the procedures and the post-procedural care. So just in terms of if you have a patient with aortic stenosis, we always need a transthoracic echocardiogram. That's the cornerstone of diagnosis. We need a CT TAVR. CT TAVRs are different from typical kind of CT chest with contrast because it has to be ECG gated. We currently are still doing coronary angiograms, but as we are going to move to a phase where we use the CT TAVR to assess the coronary arteries and hopefully avoid having to do a coronary angiogram in patients who we know have normal coronary arteries. Once all of this is done, I see them in the valve clinic together with our surgical colleagues, and then we make the plan for the patient. The reason why the CT has to be ECG gated is that the aortic annulus is not a static structure and actually changes in size and dimension throughout the cardiac cycle. we always want to measure it at its largest point, which is typically 20 to 30% after the onset of systole. And that ensures that when we do put in a valve, either surgically or via a transcatheter approach, that we put in the largest possible valve for that anatomy. The other thing that CT really tells us about is how we're going to get to the heart. So it looks at the vasculature, both at the femoral vessels and then also at the aorta and the aortic arch. And if the femoral vessels are unsuitable because of size, calcification, or tortuosity, it allows us to plan for alternate access. And sometimes we go through the carotid and sometimes we go through the subclavian. And there are some even kind of more rarer approaches that are kind of beyond the scope of this, but the CT really helps us planning how we're going to get our devices to the heart. Once we get all of that data together, we kind of put it all together to try and make a plan for the patient. So we understand the size of their aortic annulus. We look at the relationship of their aortic annulus with their coronary arteries to predict the risk of coronary obstruction. We look at their ECG to predict the risk of them needing a permanent pacemaker after the procedure. And we look at the vasculature to see if there's going to be a risk of vascular injury. With all that together, we'll see them and give them a very nuanced risk assessment for their procedure and their prognosis afterwards. A lot of you won't have been in a TAVR procedure, so I'm just going to show you what one kind of looks like. Typically, the patient comes into the hybrid OR and we obtain transfemoral access. We'll cross the aortic valve and place a stiff wire into the ventricle and use that as a rail to deliver a valve on a delivery system. We then assemble the balloon onto the valve within the aorta, and this process allows us to have a smaller French. So typically we do this through either a 14 or 16 French femoral sheath. We then carefully navigate the aortic arch, taking care not to scrape the wall, because there's often calcification on the wall of the aorta, which you could scrape off and cause a stroke if it embolizes the head and neck vessels. And then we carefully bring that down to the position of the diseased stenotic calcified aortic valve. We then take a little bit of time to position this so that it's central in the valve, so that we know that when we deploy or we inflate the balloon, that the valve will deploy in a kind of stable and predictable manner. We then rapidly pace the heart, which essentially causes ventricular standstill, and inflate the balloon, deflate the balloon, and you immediately have a competent and functioning aortic valve. The diseased calcified leaflets kind of push into the sinus of Valsalva, which is a kind of space which is perfectly designed to take those redundant calcified leaflet tissues. And then we remove the delivery system and the wire from the heart, and the patient wakes up either from their anesthesia or from their sedation and goes on to typically goes to the recovery unit and then to the floor. And we're now to the stage where the vast majority of our patients will go home on day one following the procedure. And so look, that I really want to say that we've kind of got to the stage now where TAVR, although really only first done about 20 years ago, has been shown to be as good, if not better, than conventional surgery for patients with severe degenerative aortic stenosis. So what's next? Earlier this year, published in the New England Journal of Medicine, was the early TAVR study. The kind of threshold for intervention prior to this was the onset of symptoms. And so this study took patients with severe aortic stenosis that were reportedly asymptomatic. They didn't take patients' word for it. They put them on a treadmill, and they had to be able to complete a treadmill test without significant symptoms or ECG changes. And if that were true, they were then randomized in a one-to-one fashion to transfemoral TAVR or clinical surveillance. The clinical surveillance arm had the outcome of death, stroke, or unplanned hospitalization at 50% through to 5 years. That was down to 35% in the arm that was randomized to early intervention. So this really demonstrated that in severe aortic stenosis, regardless of symptoms, you can improve outcomes in patients by offering early TAVR. One really, really interesting thing here is that when we started doing TAVR with bulky first-generation systems, What we really worried about was the risk of stroke with TAVR. In this, and this is really showing us contemporary our data from the TAVR, and this is through to 5 years, your risk of stroke with TAVR is lower than your risk of stroke with medical management of aortic stenosis. Not only was that seen in this study, but there were two other studies that were published earlier this year looking at asymptomatic aortic stenosis, looking at early intervention, and they all showed the same trend that your risk of stroke is lower with the procedure than without. And that's kind of helping redefine how we have these conversations with our patients who are often most worried about having a stroke. There was no significant, there was a trend to a lower, numerically lower mortality, but no significant difference. And there was a vast difference in unplanned cardiovascular hospitalization. And that's not uncommon. These are elderly patients that often have other things wrong with them. And an elderly patient with a normal aortic valve with a pneumonia can often tolerate it very well. An elderly patient with severe aortic stenosis who has a pneumonia typically may have a much higher threshold to decompensate. And so this is kind of, we're not going to go into this into too much detail, but a lot of the patients, the median time to conversion was 11 months in these patients. And the vast majority of these patients were presenting to the hospital with NYHA class 3 to 4 symptoms, requiring kind of more timely intervention. There were patients, and about a bit more than half presented the clinic with worsening symptoms. And then there were some patients that actually ended up having valve replacement in the absence of symptoms, typically for if they were having other procedures that their anesthesiologist or the other surgeon required the aortic valve to be treated prior to them having some other procedure performed. So again, across all of the kind of heart failure hospitalizations, we're seeing that asymptomatic patients will benefit from therapy. And that really is changing the mindset in terms of how we manage patients with aortic stenosis. And we're no longer waiting for symptoms to start, but we're trying to assess them early. And it's not saying we're going to treat every patient without symptoms with that severe aortic stenosis, but I think it's worth having these patients assessed so we can make an individualized assessment based on the risk of the procedure for them and the potential benefit that they would have. The other thing that the early TAVR data really showed us was it gave us contemporary data, albeit now at least 5 years out of date, of what the outcomes are for TAVR. In that study, 1 in 5 patients were routinely having general anesthesia. The median procedure time was 40 minutes. These are really important things when talking to patients about what TAVR entails for them. The procedural outcomes were remarkably good. They actually reported a 0% risk of a 0% incidence, of cardiovascular death, a less than 1% risk of stroke, a less than 2% risk of vascular complications, and a less than 6% risk of pacemaker. This is vastly, vastly different to what TAVR looked like 10 years ago. But it kind of shows that with both procedural refinement and iterative improvements in the technology, we've really made this a much lower risk procedure than it was before. That being said, complications do still sometimes occur, and it's important to be able to recognize them and manage them appropriately. The kind of complications that we really think about and talk to our patients about are vascular injury, heart block requiring a pacemaker, pericardial effusions or even tamponade, and stroke. So here's just an image of a post-TAVR patient that unfortunately completely had laceration of their iliac artery causing huge hemorrhage. The vast majority of vascular complications are recognized in the hybrid OR and are dealt with prior to the time the patient leaves the operating room. Typically, they can be dealt with an endovascular technique, either with covered stents or with other closure devices. Often they can be predicted by the CT scan. We look at the size of the vessels, the calcification of the vessels, and tortuosity. In the post-TAVR patient, if a hematoma arises or if there's kind of obvious bleeding, someone needs to hold pressure immediately whilst we make a plan. Like never leave a hematoma kind of unaddressed. Someone needs to have their hands on it straight away. If there's concerns for ischemia, such as a cold leg or absent pulses in the leg that were previously present, we need to try and assess the patency of that vessel. And depending on the clinical situation or the kind of feeling of risk of intraprocedural complication, that patient will either return to the cath lab or the OR for invasive angiography to look at the patency of the vessel, or they'll have a Doppler ultrasound to look to see what the vessel is like. The other way that kind of bleeding injuries can occur, and hopefully this is more rarer now, is with the retroperitoneal hematoma. You may not see a hematoma on the skin, but the patient may develop hypotension and tachycardia afterwards, and it means that they're bleeding in a similar way, but into the retroperitoneal space. Those patients need to have fluid resuscitation and, again, either a CT scan to diagnose the retroperitoneal bleed or return to the lab if their suspicion is very high for kind of both diagnosis and intervention. Heart block is common. It's more common with self-expanding valves than the balloon expandable valves. And the risk for the balloon expandable valves is really between 5 and 6%. The risk for the self-expanding valve is between 10 and 15%. It's related to the membranous septum, which sits immediately below the aortic valve. And this anatomy is varies between patient and patient. You can actually use the CT to predict your risk of heart block, but a better predictor of heart block is if the patient has a pre-existing right bundle or any kind of conduction disease on their pre-existing ECG. That definitely kind of puts our attention up to the risk of heart block following the procedure. Patients are all on telemetry after a TAVR procedure for a minimum of 24 hours. If they have broadening of their QRS or worsening of the PR interval, then we may require them to have kind of outpatient rhythm monitoring. With the balloon expandable valves, the kind of sapien implants that you'll see, typically if the patient has conduction disease, it'll be at the time of implant. With the self-expanding valve, and the typical ones that are commercially available are the Evolut valve or the Navitor valve. Those valves continue to expand in the 24 hours or 48 hours after implantation. So it's not uncommon with them to see later AV block. So that's why we keep these patients on telemetry for 1 or 2 days afterwards to make sure that their conduction remains intact. Stroke is the most terrifying of the complications. Thankfully occurs in less than 1% of patients now, often due to calcified embolized material, not thrombus. Therefore, thrombolysis or thrombolytics will not be effective. Typically, if it is there and we see a large filling defect, that's a consult for neurointervention to see if we can try and mechanically remove that occlusion. We've tried multiple different filter devices to try and reduce the risk of stroke. None have been demonstrated to be effective. I would caveat this with one kind of practical warning. We need to be convinced clinically that the patient's had a stroke. When we do MRI scans in patients post either TAVR or even surgical aortic valve replacement, we will see white matter changes. We will see evidence of perfusion defects. That's just part of being part of the procedure. But we need to be careful that generally have a very high threshold for cross-sectional imaging of the brain following a changes. The other thing to see, which may represent vascular or cardiac injury, is pericardial effusion. Again, very rare, again, often predicted by the CT scan. You should definitely think about a stat echo in patients who've got unexplained hypotension. Definitely, if we see a pericardial effusion, we need to kind of fluid load these patients. And if there's evidence of tamponade, we may need emergent pericardiocentesis. Can arise from injury to either the left ventricle, the right ventricle, or the aortic root. Often the only way to figure that out is by getting some of the blood out to see if it looks like oxygenated or deoxygenated blood. And if the patient has had bleeding causing pericardial effusion, we may rationalize the antithrombotic medication in the post-procedural setting. So that's kind of where TAVR is currently, common complications and how to manage them. There's also these whole other different categories there that TAVR is now encroaching into, from bicuspid aortic valve disease or aortic regurgitation. I'd say patients with previous surgery, previous aortic valve replacement, TAVR is now the default. It's so much safer than redo surgery and so much quicker and easier that any patient who's had degeneration of a previous bioprosthesis, we now think of as TAVR first and only consider surgery if TAVR is not an option. And then we've also got data that even if patients have coronary artery disease, they do better with TAVR and PCI than they do with surgical aortic valve replacement with CABG. So bicuspid valve disease is very different. It's in a younger population than the degenerative trileaflet aortic valve disease, and it's very, very heterogeneous. Most degenerative trileaflet aortic valves look very similar. Bicuspid valves look very, very different, both in their morphology, their relationship with the sinuses, and the distribution and burden of calcification. CT is really crucial here to understanding the morphology and the disease burden. That said, when we look across population levels, and this is from TVT data, when we compare matched patients with bicuspid aortic stenosis to tricuspid aortic stenosis, we're seeing that the outcomes we get in bicuspid aortic stenosis are as good as those with degenerative aortic stenosis and treated with TAVR. And that's both in regards to mortality and stroke. But I would have a kind of big caution here. This is observational data. The surgical outcomes for bicuspid aortic valve disease is excellent, and I wouldn't necessarily translate TAVR outcomes in that different pathology. And it's a very heterogeneous group. We've demonstrated with the TVT data that we can get good outcomes, but that's in a very, very select population where we carefully consider the risk of TAVR in these patients. So this is definitely not an all-comers though. And to the point when I'm referred a bicuspid aortic valve for TAVR, I refuse to give an opinion until I've seen the CT, because we're not in the business of replacing low-risk surgery with high-risk TAVR. But if TAVR is an option and TAVR is safe, then TAVR can be an option for some patients with bicuspid aortic valve disease. There's lots of things that we look for on the CT that tells us about the risk, and it's mostly with regards to the distribution and extent of calcification, the relationship of the coronary arteries, which may represent the risk of coronary artery occlusion, and the presence of aortopathies. Aortopathies are commonplace in patients with bicuspid aortic valve disease. If a patient needs concomitant aortic root replacement, then obviously surgery is the way to go. The other thing is aortic regurgitation, again, very common, associated with bad outcomes as symptoms worsen. In the current guidelines, TAVI is given a class 3 recommendation, which is a do not do it, unlikely to work. I think we can now challenge that to say that TAVR in aortic regurgitation can be considered in select populations, and we'll soon have dedicated devices that will allow us to do this in kind of more mainstream people. The problem with aortic regurgitation is that we lack the calcified disease scaffold that aortic stenosis have. The calcified leaflets in aortic stenosis provide us the scaffold for the valve to anchor and remain in place. In aortic regurgitation, it is not a disease of calcification, and so we have to think how we're going to get these valves that are designed for stenotic leaflets to stay in place. And as a result of those, if you haven't planned it properly, there's a risk of embolization, there's a risk of aortic root rupture, there's a risk of continual aortic regurgitation. There's lots of technical features that make TAVR for aortic regurgitation much higher risk, but not impossible. And this is just an example, 77-year-old lady, high surgical risk because she's had a previous stroke and she's got carotid disease. She has severe aortic regurgitation. She's got no calcium on her CT scan, good vasculature. The coronary heights are nice and high. We're not going to obstruct them. And we do 3D reconstructions of all the CTs. I do these myself so that we can fully plan and make sure that the procedure is as safe as possible. And this patient, essentially, we just oversized a balloon annulus and didn't have any aortic regurgitation. She again went home on day one. Her symptoms completely abated. Her echo showed she had a normally functioning valve. So in carefully selected aortic regurgitation patients, we can use off-label use of TAVR devices to treat these patients. What's coming up next is dedicated devices for aortic regurgitation. And this is just one example of them. This is called the JenaValve, which completed its single arm registry in the US last year called the Align AR study, in which they took patients at high risk of surgery and treated them with the JenaValve and demonstrated excellent outcomes. That was published in the Lancet and is currently the technology is currently under review by the FDA before it becomes commercially available, hopefully at the end of this year, maybe next year. This is just an example of how the JenaValve works, and it's kind of slightly different. We've got these locators that we carefully place on the outside of each aortic valve leaflet, and then within it, we deploy a valve. We kind of deploy a valve, so we capture the valve leaflets between those locators and the self-expanding valve, and that's how it anchors in place. It seems more complicated, but actually we can get this done in 45 minutes without much issue. And again, the patients have a similar clinical course with going home on day one typically. So that's kind of, there's a lot more to talk about TAVR than we've covered here, but that's kind of the main things that we wanted to talk about. Aortic valve disease and aortic regurgitation. And so I think I've got a few minutes now, but I'd really open it up to kind of questions to see what I can answer in terms of how best to manage these patients or patients that may or may not be suitable for therapy.
While we're waiting for if there's anybody else with questions, but I just had a question about how long do these valves generally last for?
Yeah, so that's a very common question that we get in the valve clinic. So we know from the surgical aortic valve data, we typically say these valves typically last between 10 and 12 years. There's a huge amount of variance between that. Some of the valves last 5 or 6 years, some of them last 15 years. And there's patient factors that affect that. And one of the bigger things is renal dysfunction. Patients with dialysis, for some reason, chew up their tissue valves. We have no reason to believe that valves that are done with TAVR will be any less durable than the valves done with surgery. We've got data through to 10 years in the NOTION study suggesting similar durability. The issue is that when the patients that we were putting the valves in 10 years ago were kind of in their mid-80s, and so often died of another reason rather than their valves. So we don't have, only since 2020 have we been doing low-risk patients in the US, and so it'll take another kind of 5 to 10 years before we kind of we can say with more certainty about the durability. But definitely there's no signal in the data so far that they're any less durable than surgical aortic valve replacements.
For USC, which type of valve do we use? Like which do you use the balloon, like the balloon deployment more, or do you use like the self-expanding?
Yeah, so the program's very balanced now. I think before I came, it was 90% self-expanding. It's now 50-50% balloon expandable and self-expandable. There are nuances for the use of either technology, and a lot of that's based on procedural risk based on the CT, and a lot of that's based on lifetime management, because now we're doing younger and younger patients. Not only do I plan their index procedure, but I plan actually in 10 or 12 years time, when this valve wears out, how am I going to do another one of these? And so these are all the discussions that we have in valve clinic and considerations that we kind of take when we're choosing between TAVR and surgery, and also if they go down TAVR, when we choose their valve type.
Got it. Thank you. There was actually another question from the audience that because I think you spoke about it earlier, like that was published in the New England about doing TAVRs for asymptomatic severe AS. Is that now part of the guidelines now with that article published, or it's still?
No. So that's like very recent data from earlier this year. So it is not, so it's not part of the guidelines. I'm sure the guidelines will change in time. And I guess what I want to say is that it's not a blanket term. What I don't necessarily think every patient with aortic stenosis, regardless of symptoms, should be treated, especially if based on the CT, it's a high risk procedure, because we didn't demonstrate a reduction in mortality. But what I do think is that every patient with aortic stenosis, with severe aortic stenosis, should be assessed in the valve clinic. We should be able to see these patients and have a discussion with them, understand what their individualized procedural risk is, and have a kind of discussion with them about what the future might hold and what the pros and cons of watchful waiting versus early intervention.
Got it. I mean, this is from more of a financial thing too. Whether do you have you had issues with insurance covering for this procedure if it's like
No. So
automatic?
so now, as long as it's aortic stenosis, there's no real issue with insurance. The economic cost benefit analysis is profoundly in favor of doing TAVR, just because you can wipe out the cost of a TAVR with one unplanned heart failure hospitalization. So it's like there's now almost no kickback. There's almost no kind of um, problems with getting aortic stenosis TAVR approved. We do get issues when we're going off label, when we're going to aortic regurgitation. That becomes an issue because it's definitely not in the guidelines, not outside of the FDA recommendation. And our general approach is we always do the right thing for the patient, and we'll find a way to do the right thing for the patient, regardless of what the problems insurance give us.
Got it. I'm gonna see if anybody else have any questions. But
Hey, this was a great talk. Thank you. I was just wondering if those initial graphs you were showing, was that all-cause mortality or is that CV mortality or was it broken down?
So the very first graph which I showed you was from the Partner A study, and that was all-cause mortality with a 50% reduction with TAVR.
Got it. Thank you.
Great. Well, thank you all for your attention. Hopefully this has been insightful. And yeah, I'm always available via phone or email if you have any questions about these patients. And the Valve Clinic will happily see any patient that you want us to have a look at.
yeah, thank you so much, Dr. Joseph. It was a great talk.
Thanks. Okay.
And for everybody else, for the MOC, please email Brandon. He's gonna put in the chat in terms of like, so message him that your date of birth doesn't need to be the year as well as your name. And
Okay.
the answer, I'm assuming it's lower stroke for everybody. I believe that was like
Yeah, it was lower stroke.
I think it's
So yeah,
usually-
lower stroke. So and very interestingly, lower stroke compared to surgery, but potentially lower stroke compared to doing nothing, which is a
yeah.
wild progression of where we've come to with this technology.
Perfect. Brandon just posted in chat. Thank you so much again, Dr. Joseph, for taking the time out from your conference in New York. And then thanks everybody for attending. We're going to end the session.